so I will just proceed directly into my talk. Just to clarify, I'm an associate professor at the Duke NUS rather than the other National University of Singapore. Just to illustrate the talk a little bit, I'll talk a little bit about a patient of mine named Kay. She had up to 2B of ABVD, achieving only a very poor partial remission, and therefore went on to 6 cycles of escalated Beer-Corp, achieving slightly better but still quite poor partial remission. Received involved field radiotherapy, and still having residual disease, and blowing back substantial disease later, and receiving 4 cycles of ICE in the hope of subsequently going on to autologous transplantation, but was still not in remission. So it's on this background that I will proceed on to the rest of the talk. So the role of autologous or allogeneic transplantation in Hodgkin's lymphoma, I think some things I'd like to discuss. For autologous transplantation, what's its role in relapse disease? What's its role in high-risk or primary refractory disease? For allogeneic transplantation, what's its role in relapse after autologous transplantation? Or what's its role in earlier relapse or refractory settings? Firstly, for autologous transplant in relapse disease. We feel that autologous transplant in first relapse is current standard of care. We know that conventional chemotherapy can achieve overall response rate of up to 85% in relapse disease, and even PET negativity in up to 60%. However, responses are durable only in a small percentage. As seen in this curve, for patients who relapsed within less than a year of initial chemotherapy, salvage chemotherapy could give some long-term survivals in a very small percentage of patients. And in those who relapsed more than a year after initial chemotherapy, survival was slightly better with salvage chemotherapy, but still a pretty small percentage long-term survival despite the late relapses. So can autologous transplants do better than that? In the studies done in the 1990s, for example, by Lynch in 1993, comparing mini-beam chemotherapy versus beam conditioning and autologous transplantation, we can see that autologous transplants perform better. Comparing also DEXA beam against beam and autologous transplantation, you can see that autologous transplants will perform better for patients presenting in first relapse after initial chemotherapy. So autologous transplants in relapse disease, after you've achieved another remission, most certainly. What about for high-risk or primary refractory disease upfront, before relapse? Oops. You can see in this patients with high-risk disease, comparing, this is not comparing. Auto transplants for patients performed in first complete remission or partial remission, looking at overall survival as well as progression-free survival. Pretty good survivals for these patients. And also, if you look at the whole group of patients who were transplanted upfront for Hodgkin's, high-risk Hodgkin's lymphoma, pretty good survivals. However, if the patients were refractory, survival is less good. And if they did not actually receive adequate remission, also survival is pretty poor. So this is another study comparing patients who all had clinical stage 4 disease, mediastinal mass of 0.45 in thoracic diameter, so defined as high-risk Hodgkin's lymphoma, and then subsequently had an incomplete response after first-line chemotherapy. The patients were compared in those who received autologous stem cell transplantation, receiving conditioning with BEAM, CBV, or cyclo-TBI, against those who received subsequently extended field radiotherapy, chemotherapy, or chemotherapy plus extended field radiotherapy. Patients who receive an autologous stem cell transplant appeared to do better than patients who receive combined modality therapy. The difference is particularly marked in those who had less than a 50% initial response to initial therapy. So in patients who had less than a 50% response to initial therapy, autologous transplantation appeared to be able to give substantially more benefit in these particular patients. However, we also know that if you do proceed on to autologous stem cell transplantation, survival is quite different depending on how much disease the patient has prior to autologous transplantation. If the patient remains PET positive, survival remains quite poor. If PET positive prior to autologous stem cell transplantation, survival remains quite poor. If they are PET negative, survival is better. If they are PET negative as well as extranodal site negative, survival is even better. So PET positive disease and extranodal involvement at time of stem cell transplant are the most important predictors of outcome and whether or not patients needed more chemotherapy. So I would say for autologous transplantation, we do it in relapse disease, but also probably in primary refractory disease, we will try to salvage the PET negativity. In high-risk disease, per se, if they are not having residual disease at that time after initial chemotherapy, it is doubtful. What about the role of allogenic transplantation? We do seem to see clinical evidence of a graft versus Hodgkin's lymphoma effect after reduced intensity allogenic transplantation. In this study in the UK, you can see that patients who had graft versus host disease, especially with chronic extensive graft versus host disease, the incidence of relapse appears to be much less compared to those with limited chronic graft versus host disease. In addition, if patients had a good response initially to donor lymphocyte infusion, the chance of response to the therapy appeared to be better. The role of graft versus host disease in Hodgkin's lymphoma appears to be mediated by T cells coming from the donor, cytotoxic T cells. And this interacts with, especially in this particular study, where substantial use of alemtuzumab was used, and where donor lymphocytes could enhance the graft versus Hodgkin's lymphoma effect. We, however, do know that myeloablative allogenic transplants should be avoided in Hodgkin's lymphoma. In this report from the CIBMTR, we can see that overall survival in these patients was only 37% at 1 year, and disease progression seen in 45% at 1 year in patients who received myeloablative allogenic transplantation. And transplant-related mortality was 20%. So the results for myeloablative allogenic transplants do not appear to be very good. Reduced intensity conditioning transplants appear to be better in terms of reducing some of the transplant-related mortality, but it is still reasonably substantial, 16% to about 23 to 25% in these patients. Progression-free survival ranged from 18 to 55% in these patients, depending on the type of patient selection, as well as the prior regimens before transplantation, as well as the type of conditioning that the patients underwent prior to transplantation. So the role of allogenic transplants at that point, there appeared to be some role, but with some uncertainty. However, in a comparative study looking at the role of allogenic transplantation for patients who relapse after autologous transplantation, a donor versus no donor analysis was performed. In this group of patients, there was a fairly even age distribution in the two patient groups, a fairly even sex distribution in the two patient groups as well. Most of the patients relapsed less than 12 months after after autologous transplantation, and most of the patients had nodular sclerosis subtype. And the distribution was fairly equal between the donor, non-donor group. Conditioning regimen used for transplantation was mostly fludarabine, cyclophosphamide, and tiotepa, with some patients receiving fludarabine melphalan, some other patients receiving fludarabine, tiotepa, cyclophosphamide, fludarabine busulfan, as well as other conditioning regimens. So in this donor versus no donor analysis, you can see that progression-free survival was substantially better in patients with a donor and therefore went on to an allogenic transplantation after initial relapse after autologous transplantation, both in progression-free survival as well as overall survival. In a multivariate analysis of progression-free survival and overall survival, you can see that no donors do much less well than patients who had donors, with a significant hazard ratio. In patients who had relapsed less than 12 months after autologous transplantation, they also did less well than patients who had relapsed more than 12 months after autologous transplants. In a multivariate analysis of only the allogenic transplant patients, patients who had complete remission did better than those who had partial remission or progressive disease. In patients who had graft versus host disease, especially chronic graft versus host disease, chronic graft versus host disease patients did better than those who had no chronic graft versus host. However, acute graft versus host disease did not seem to confer a benefit. Based on this study, I would say that allogenic transplantation, there's a role in patients who have relapsed after autologous transplantation. What about in earlier relapse or refractory settings? Now, there are multiple studies being performed in this setting, so I will only cite one. This is patients who receive brentuximab vedotin in patients who have relapsed or refractory Hodgkin's lymphoma. You can see the overall survival, progression-free survival of these patients. Pretty good despite a relapse refractory setting after achieving remission with brentuximab. I believe my next speaker will probably talk about this drug in greater detail. So in our particular patient, we classified her at this point as a refractory patient after all the rounds of treatment that she had received. We were not confident of proceeding on to autologous transplantation because of the lack of a very good remission after ICE therapy. She received two rounds of, at that time it was called SGN30, and a reduced intensity allogenic stem cell transplant with fludarabine, melphalan, and ATG. She received an 8 of 8 match unrelated donor transplant. After initial salvage, you can see there was reduction in disease after ICE salvage. After brentuximab, however, the disease went into remission, although with a bit of residual, possibly non-significant masses. And 1 year after her allogenic transplant, she still has no recurrence of disease. more than a year after initial allogeneic transplant, still has no recurrence of disease, and it continues to do well. So I would say allogeneic transplantation could possibly have a role in earlier relapse refractory settings. It may be possible with better pre-transplant remission and post-transplant salvage. So conclusions. Some things may be still debatable, but I would say that high-dose therapy with autologous transplant is standard of care for patients with first relapse or primary refractory disease, provided a remission can be achieved with salvage therapy. The goal of salvage therapy before autologous transplant is to achieve PET negativity as far as possible. Patients with relapse disease after autologous transplantation should undergo an allogenic transplant, provided they achieve at least a partial remission with salvage therapy. One thing that I did not go into was the tandem autologous allogenic transplant approach, which can be considered in patients with primary refractory or relapse disease who have incomplete response to salvage therapy, which I could have employed in my patient as well. But we did not deem her fit to undergo both autologous followed by allogenic transplant at that time. There's a potential to combine new agents with potential graft versus Hodgkin effect of allogenic transplants. Thank you very much, and I'd like to thank Dr. Colin Deong, Director of the Lymphoma Service, for providing some of the slides. Thank you.